Welcome back to the Deep Dive. Today we are opening the books, and quite literally, on one of the most complex, fascinating, and frankly devastating battlegrounds in the human body.
We're going big today.
We are. We're tackling Chapter 75 of the legendary Baily and Love's Short Practice of Surgery, the 28th edition.
Ah, yes. The Big Blue Book. A tome that has sat on the shelf of nearly every aspiring surgeon for decades. It's, practically the Bible of the operating theater.
I've heard if you drop it on your foot, you'll break a toe.
You definitely will. But if you read it, you might just save a life. So it's worth the risk.
Exactly. And our mission today is, well, it's very specific. We're aiming to create a ready reckoner for the medical students, the surgical trainees, and, anyone who's just insanely curious.
So we're not just reading from the book.
No, absolutely not. We're going to interpret this chapter. We want to take these dense concepts around inflammatory bowel disease, IBD, and use some narrative glue, some metaphors, to really make them stick.
Right. And it's probably worth saying, just a quick disclaimer before we dive in, this conversation is a revision guide. It's a deep dive into the concepts. It absolutely does not replace reading the text.
100%. You still need to go and look at the histology photos, the diagrams of the operations in Chapter 75.
We're here to provide the context, the framework, and maybe the why behind the what. Think of us as, the Sherpas guiding you up the mountain. You still have to do the actual climbing.
I love that. So let's set the hook. We're talking about a civil war in the gut. The body, for reasons we don't fully understand, attacking itself. Specifically, we're looking at the twins of IBD.
Ah, the twins that aren't identical.
Exactly. They seem similar at a glance, but are actually very, very different beasts: ulcerative colitis and Crohn's disease.
I often think of them less as twins and more as maybe neighbors who really don't get along.
Okay.
They share the same territory, the intestines, but they behave in completely different ways. And getting them mixed up isn't just a minor error on an exam paper.
In the real world, it's a big deal.
In the real world, mistaking one for the other can lead to, surgical disasters.
High stakes right from the start. And for you listening right now, whether you're scrubbing up for a subtotal colectomy or you're, sitting in the library cramming for finals, this is for you.
Let's start with the big picture, the view from 30,000 feet.
Right. Geography and cause. What does Baily and Love tell us about where this happens? Who gets it?
It's an interesting geographical divide. We traditionally see a north-south split. The highest prevalence is in Europe and North America. We're talking around 3 in the 1,000 people. So it's not a rare disease.
Historically a disease of the West, then?
Yes, predominantly. But, and the text highlights this as a crucial shift, the incidence is steadily, and I mean steadily, rising in Asia.
Which seems to correlate with industrialization, doesn't it? We see skyscrapers go up, and suddenly IBD cases follow.
Precisely. As urbanization increases, as countries adopt a more westernized lifestyle, so does IBD. And this feeds directly into what we call the perfect storm theory of etiology.
It's never just one thing.
Never. It's a genetic predisposition colliding with some kind of environmental trigger. The body is primed for it, and then something in the environment pulls the trigger.
Okay, let's unpack the genetics first. This is often where students can get a bit bogged down. Are there specific markers we need to bookmark in our brains?
For Crohn's disease, definitely. The text specifically calls out variants of the NOD2-CARD15 gene.
That's a mouthful. What does it actually do, in simple terms?
Okay, think of it as a security guard, or maybe a bouncer at a club, inside your intestinal cells. Its job is to recognize bits of bacteria.
Good guys or bad guys?
Well, it's supposed to identify the bad guys and raise the alarm while letting the normal gut flora, the good guys, just go about their business.
And in Crohn's, that system is faulty.
Exactly. The bouncer has bad eyesight. It can't tell the difference. So the immune system overreacts to the normal, harmless bacteria in your gut and treats them like a hostile invasion.
So your body sees a normal bacteria, panics, and basically screams, "Invader," and burns the village down.
That is a perfect way to put it. That's the inflammation. The bouncer starts throwing punches at everyone, even the paying customers.
And then you have the environmental triggers on top of that. Diet, the hygiene hypothesis.
And the famous paradox.
Ah, yes, the smoking paradox. This is one of those facts that I swear inevitably shows up on exams because it's just so counterintuitive.
It is deeply strange. I mean, in almost every other area of health, heart disease, lung cancer, stroke, smoking is unequivocally the villain. End of story.
And for Crohn's disease, that holds true.
It does. Smoking increases the risk of developing Crohn's threefold. It makes the disease course worse. It increases the risk of recurrence after surgery. It increases the need for surgery. If you have Crohn's, putting a cigarette in your mouth is like pouring gasoline on a fire.
But,
But
right,
for ulcerative colitis, for some reason, smoking appears to be protective.
that just sounds wrong to say out loud.
It does, doesn't it? It feels like we shouldn't even say it. But the data is there. Non-smokers, or interestingly, ex-smokers, are at a higher risk for UC than current smokers. We sometimes see patients develop ulcerative colitis specifically after they've quit
A
smoking.
rebound effect.
A total rebound effect. It's wild.
Okay, to be crystal clear, we are not recommending anyone take up smoking to treat their colitis.
Absolutely not. And Baily and Love is very clear on this. The cardiovascular and cancer risks of smoking far, far outweigh any potential benefit for the colon. You might save your colon, but you'll destroy your lungs and heart.
That is a clue.
As a clue, mechanistically, it's fascinating. It tells us that these two diseases, while grouped together under the IBD umbrella, must have fundamentally different drivers. They are not the same thing.
Okay, before we dive into the blood and guts of the pathology, I want to do a quick check-in.
Yeah.
For you, listening, ask yourself this. Do you know which of these two diseases is considered curable by surgery and which one is merely managed?
Just hold that thought.
Yeah, just keep that in the back of your mind, because it is the central pillar of all surgical decision-making in this field.
It changes everything.
Yeah.
How you treat the patient, how you counsel them, what operation you even offer them. If you don't know the answer yet, don't worry. We are going to drill it into you shortly.
Let's move into segment 1. The tale of two colitides. We need to define the territory, so map it out for us. Where do these diseases actually live?
Okay, let's start with Crohn's disease. The classic definition, the one everyone learns, is mouth to anus.
Or, as I learned it, gum to bum.
Gum to bum. It's memorable because it's true. It can affect any part of the gastrointestinal tract from the lips all the way down. You can have oral Crohn's, esophageal Crohn's, gastric Crohn's. It's an equal opportunity offender.
But it has a favorite spot, right? A preferred hang-up.
It does. It absolutely loves the terminal ileum. That's the very last part of the small bowel. And the ileocecal region, which is where the small bowel joins the large bowel. But, strictly speaking, it can be anywhere.
Okay, so that's Crohn's. What about ulcerative colitis, UC?
UC is much more predictable. It is strictly a disease of the large bowel.
It respects the boundaries of the colon.
Completely. And it has a very specific marching order. UC almost always starts in the rectum. We call that proctitis. And then extends proximally. It marches upwards through the colon.
In a continuous fashion.
Yes, that's the key word. Continuous. It doesn't skip areas. It's like a relentless wave of inflammation moving up from the bottom.
Okay, I want to try and use some anchor metaphors here to help visualize the histology, because reading about crypt abscesses and goblet cells can get pretty dry.
Go for it. Visuals are absolutely key here. If you can see it in your mind, you can diagnose it.
So for ulcerative colitis, I want you to imagine a red carpet, specifically a superficial red carpet that has been burned or ulcerated.
Okay, I'm with you.
The inflammation is mucosal. It's only the top layer, the carpet itself. It doesn't dig deep into the floorboards underneath, and just like a carpet rolling out from the door, it starts at the rectum and rolls backwards into the room continuously.
I like that. So there are no patches of normal floor showing in between the burnt carpet.
Exactly. It's a continuous burn.
And that burn, in your metaphor, histologically, that manifests as things like crypt abscesses, little pockets of pus in the glands of the colon lining. You also see goblet cell depletion.
So the mucus-producing cells are just wiped out.
Necked out. And another term you'll see is basal plasmacytosis. It sounds complicated.
It does sound like a mouthful.
But all it means is you see these inflammatory plasma cells deep down where they shouldn't be. It's a sign of chronic inflammation. So if you see continuous inflammation and mucosal involvement only, think red carpet. Think UC.
Okay, so UC is the superficial red carpet. Now, for Crohn's disease, I want you to imagine tunneling moles.
Moles. Okay.
Yes, because Crohn's is transmural. It's full thickness. It digs right through the entire wall of the bowel, from the inside lining to the outside skin. It's tunneling.
Like a mole digging through all the layers of the soil.
Exactly. And moles don't dig a straight, continuous trench. They pop up here, dig a bit, then pop up over there. That explains the skip lesions. You have a patch of diseased bowel, then a totally normal patch of bowel, then another diseased patch.
That aligns perfectly with the text. And this full-thickness transmural inflammation is what leads to the specific complications we see in Crohn's. Because it burrows through the wall, it creates fissures and fistulas.
Literal tunnels.
Literal tunnels connecting organs that should never be connected. A fistula could run from the bowel to the bladder, the bowel to the skin, or one loop of bowel to another loop of bowel.
And when you look inside the bowel with a scope, you see that famous cobblestone appearance.
Right. If you imagine a cobblestone street, you've got the stones sticking up and the deep cracks in between. In Crohn's, the deep, knife-like linear ulcers are the cracks, and the surviving mucosa puffs up like the stones themselves because of all the swelling, the edema.
And we can't forget two other massive visual markers for Crohn's. One is fat wrapping.
Yes, creeping fat. It sounds like something from a horror movie. The mesenteric fat, which is the fatty tissue that holds the intestines, literally creeps from the mesentery around the surface of the bowel wall. It's almost as if it's trying to bandage the inflammation from the outside.
You can see this during surgery.
Oh, it's a dead giveaway.
Yeah.
You open the abdomen, you look at the bowel, and you can't see the wall clearly because this dense, overgrown fat has wrapped itself around it.
And the other key marker is the granuloma.
The hallmark, the non-caseating giant cell granuloma. If you see that on a biopsy, it's Crohn's. Full stop. But, and this is a huge exam trap, it is only present in about 60% of cases.
So the absence of granulomas does not rule out Crohn's.
It absolutely does not. That's a crucial distinction. You can have Crohn's without the granuloma, but you pretty much never have the granuloma without the Crohn's.
Got it.
And sometimes you just can't tell. In about 10% of cases where the colon is removed, the pathologist looks at the slide and says, honestly, I don't know. It has features of both. We call that indeterminate colitis. It's the gray zone.
Okay, let's try and ground this with some people. I want to introduce two fictional patients just to anchor these concepts. Let's call them Ursula and Christopher.
Okay, bring them to life.
So Ursula has ulcerative colitis. What's her life like on a bad day? What's her story?
Ursula is likely dealing with bloody diarrhea. That is the cardinal symptom. It's bright red blood. It's frequent. She has urgency, the feeling that she has to go right now. And she has tenesmus.
Can you define tenesmus for us? It's a very specific feeling.
It's that awful, distressing sensation of incomplete evacuation. She feels like she needs to pass stool even when she's just been at the toilet. It's because the rectal inflammation is making the nerves there hypersensitive.
So it's a constant discomfort.
A constant nagging feeling. Interestingly, she might not have that much severe abdominal pain unless she's in a really severe flare. It's mostly about the blood, the frequency, and the anxiety of always needing to know where the nearest toilet is. Ursula maps every bathroom in the city before she leaves the house.
Now let's meet Christopher. He has Crohn's.
Christopher's picture is different. He likely presents with abdominal pain as a primary symptom, often in the right iliac fossa.
Why the right side specifically?
Because remember, Crohn's loves the terminal ileum, and the terminal ileum sits in the lower right abdomen. It's a classic mimic of appendicitis.
Ah, okay.
He might have significant weight loss, which is a huge red flag. His inflamed small bowel isn't absorbing nutrients properly. That's something Ursula, with her large bowel-only disease, doesn't usually face.
And the diarrhea might be different.
It might not even be bloody. It could be more watery. And he's the patient who might have a perianal abscess or a fistula that just won't heal.
Yeah.
He's the guy who's been losing weight for 6 months, feels tired all the time, thinks it's stress, but his stomach hurts every time he eats.
So Ursula is bleeding and running to the bathroom. Christopher is in pain, losing weight, and maybe has a palpable mass in his right side.
That's the classic distinction. Of course, real life is always messier, but those are the textbook archetypes you need to know.
Let's move to segment 2, measuring the storm. So Ursula is having a really bad week. How do we know if she needs to be in the hospital? We need to talk about the True Love and Wits classification.
Yes, this is non-negotiable. It's essential exam knowledge and essential ward knowledge. Sidney Truelove and Leslie Witz developed this back in the 1950s at Oxford, and we still use it today because it's simple and it works. It classifies the severity of a UC flare.
Break it down for us.
Okay, so first, mild disease. Fewer than 4 stools a day, maybe a little bit of blood, but no systemic signs of illness. She's unhappy, but she's stable.
Okay, manageable.
Then, severe disease. This is the danger zone, and the criteria are very specific. More than 6 bloody stools per day, plus evidence of systemic toxicity.
Systemic toxicity is a bit vague. What exactly are we looking for on the ward?
We're looking for a body that is under stress. So a fever over 37.8 degrees Celsius, tachycardia, a heart rate over 90 beats per minute, anemia with a hemoglobin less than 10.5, or raised inflammatory markers like an ESR over 30 or a high CRP.
So it's not just the bowel anymore. The whole body is reacting.
Exactly. If you have the frequent bloody stools plus a racing heart or a fever, that is, by definition, severe acute colitis, that patient needs to be admitted to the hospital.
So 6 bloody stools plus a sick body. Severe. What's the level beyond that?
That would be fulminant disease. This is catastrophic. We're talking more than 10 stools a day, continuous bleeding, needing blood transfusions, and crucially, abdominal distension and tenderness.
And this is where we start to worry about the big surgical alarm bell.
Toxic megacolon.
It sounds like a 1950s horror movie title, Attack of the Toxic Megacolon.
It's a genuine surgical emergency. It is. If the inflammation goes deep enough and in a fulminant UC flare, it can erode into the muscle layers. It paralyzes the muscle of the colon wall. The colon loses its tone and it just dilates. It blows up like a balloon.
And there's a specific measurement for that.
There is. A colon diameter greater than 6 centimeters on a plain abdominal radiograph. That is the definition of toxic megacolon.
6 centimeters is the cutoff.
Yes. It's a sign that the colon wall is becoming paper thin and is at imminent risk of perforation. If it perforates, the mortality rate is incredibly high. You have hours to turn that situation around, not days.
Now, let's talk about investigations. We have labs like calprotectin, which is a great marker for gut inflammation. But let's talk imaging. We mentioned the string sign of Cantor in the outline. That sounds like a Sherlock Holmes clue.
It does, doesn't it? It's a classic sign, and it's specific to Crohn's. Remember we said Crohn's causes transmural inflammation? Well, over time, that healing and scarring cycle leads to fibrosis. The bowel wall gets thick and rigid, and the lumen, the actual tube, gets narrower and narrower.
It becomes a stricture.
It becomes a stricture. So when you do a contrast study, like a barium follow-through or a CT with oral contrast, that narrow, tight channel looks like a frayed piece of string connecting the healthier bowel loops on either side. That's the string sign of Cantor.
A sign of chronic fibrotic Crohn's. And for UC, is there a classic sign?
Yes. In chronic UC, the colon loses its hostra. Those are the normal pouches or segmentations that make the colon look like a string of sausages.
Right, the puffy cloud shapes on an X-ray.
Exactly. That's all gone. The colon becomes a smooth, rigid, featureless tube because of the muscular shortening from years of inflammation. On an X-ray, we call it the lead pipe colon.
Lead pipe for UC, string sign for Crohn's. Okay, check in time again. If you're listening, pause here if you need to. Can you recite right now the criteria for severe disease according to True Love and Wits?
If you can't rewind 60 seconds and listen again, I'm serious.
This is the thing that determines whether your patient gets oral meds at home or gets admitted for IV steroids with a surgeon standing by their bed. It's that important.
It is literally a life or death assessment. Don't gloss over it. Knowing the difference between mild and severe is the difference between good management and, well, negligence.
Moving on to segment 3, the medical pyramid. Now, we aren't pharmacologists, but as surgeons, we absolutely need to know what our patients are taking and why.
And we need to know that the whole philosophy of treatment has changed significantly. We used to always do a step-up approach.
Start weak, get strong.
Exactly. Start with the gentlest drugs and slowly escalate if they failed. But now, especially for Crohn's, there's a big move toward top-down therapy.
Hit hard and early. Why the switch?
Because we realized that with the step-up approach, by the time you finally got to the powerful drugs, the bowel was already permanently damaged. It was scarred, strictured, and beyond repair. The goal now is to hit it hard and early with biologics to induce deep remission and prevent that irreversible damage from ever happening.
Okay, walk us through the arsenal, the base of the pyramid.
At the base, we have the 5 ASAs, like mesalazine. Think of these as aspirin for the gut. They're anti-inflammatory, and they're great for mild to moderate UC, either topically as suppositories or orally.
Then you step up to?
Corticosteroids. Prednisolone. These are the fire extinguishers. You use them to put out an acute flare. They are fantastic at that. But, and I cannot stress this enough, you do not use them for maintenance therapy.
Why not? If they work so well, why not just stay on them?
Because they are, for want of a better word, dirty drugs. The long-term side effects are awful. We're talking thin skin, diabetes, osteoporosis, adrenal suppression, cataracts, weight gain, that classic Cushingoid appearance. If a patient is on steroids for months on end, something is wrong with the management plan.
They are a bridge, not a destination.
Perfect analogy. A bridge to get you to a safer long-term drug, which brings us to the immunomodulators.
Like azathioprine.
Azathioprine or 6-mercaptopurine, these are for maintenance. And a key nugget here for the exam and for safety is TPMT testing.
Okay, what is TPMT?
It stands for thiopurine methyltransferase. It's an enzyme that our bodies use to break down the drug. Now, about 1 in 300 people have virtually no enzyme activity. It's a genetic variant.
So they can't metabolize the drug.
They can't. So if you give those people a standard dose of thiopurine, their body can't break it down. The drug builds up to toxic levels and it completely wipes out their bone marrow. You can kill a patient with a standard dose if you don't test for this enzyme first.
That is a terrifying thought. So you always check the TPMT level before starting.
Always.
And at the very top of the pyramid.
The biologics, the heavy artillery. These are the anti-TNF agents like infliximab and adalimumab. They are monoclonal antibodies, targeted missiles that hit the specific inflammatory cytokines driving the disease. They have revolutionized care, often saving patients from surgery or at least delaying it significantly.
We shouldn't forget diet in all this, should we?
Absolutely not, especially in Crohn's. An elemental diet, which is a liquid feed of pre-digested nutrients that require zero effort from the gut, can induce remission as effectively as steroids in some cases.
Really? As good as steroids?
In children, yes. And we use it a lot in pediatric IBD because we desperately want to avoid the growth-stunting effects of long-term steroids. It's not pleasant to drink. Patients often hate it and need a feeding tube, but it works by completely resting the bowel.
Okay, the learner is listening and thinking, this is great, lots of the drugs,
Yes.
but this is a surgical text. When do we cut?
That brings us to segment 4, when medicine fails surgery for ulcerative colitis.
And here is the answer to our first check-in question.
This is it. Ulcerative colitis is the one that is cured by surgery.
Explain that concept. How do you cure what is essentially a genetic autoimmune disease with a scalpel?
Because UC, remember, is strictly a disease of the colon and rectum mucosa. That's its target organ. So if you remove the entire colon and rectum, the target organ, you have removed the disease substrate.
The disease has nowhere left to manifest.
Exactly. The patient is cured of colitis. Now, they still have the genes, and they might still get some of the extraintestinal manifestations in their liver or joints, but they will never have bloody diarrhea from colitis ever again.
So when do we pull that trigger? What are the indications?
They fall into 2 main buckets, emergency and elective. The emergency indications are things we've already discussed. Toxic megacolon, a perforation, or a massive hemorrhage.
Or, more commonly, just failing medical therapy.
That's the most common one. You admit Ursula with a severe flare. You start high-dose IV steroids. You review her on the famous day 3 review, and she is still having 8 bloody stools a day. And her CRP inflammatory marker is still high. The steroids aren't working.
The fire extinguisher is empty.
And the house is still on fire. At that point, you have to operate before she gets too weak and malnourished to tolerate the surgery.
Okay, and the elective reasons.
Often it's about cancer risk. If you've had pancolitis inflammation of the whole colon for more than 10 years, your risk of developing colorectal cancer skyrockets. So we operate prophylactically. Or the patient is just steroid dependent, their quality of life is terrible, and they are essentially a prisoner to the toilet. They choose surgery to get their life back.
So you're the surgeon on call. It's 2 a.m. You have a patient with toxic megacolon who needs an operation now. What operation do you do?
You do a subtotal colectomy and end ileostomy.
Break that down.
You take out the sick colon, the ascending, transverse, and descending parts. But, and this is the absolutely critical part, you leave the rectum behind.
Why? If the rectum is diseased too, which it probably is, why not take it all out in one go? Why leave a sick stump of bowel in the pelvis?
Because the patient is dying. They are septic, they are malnourished, they're on high-dose steroids, and their tissues are friable. They tear like wet blotting paper. A pelvic dissection to remove the rectum is technically difficult, it's long, and it's bloody.
And there are important nerves down there.
Crucial nerves for bladder and sexual function. You do not want to be doing that deep pelvic work in an unstable patient in the middle of the night. It's too dangerous. So you take the main problem, the toxic colon, out, you bring the end of the small bowel out as a stoma, and you either close the rectal stump, creating a Hartmann's pouch, or bring it out as a small mucus fistula. You get out. You save their life.
You live to fight another day.
Precisely. You save the complex bit for when the patient is healthy.
So fast forward 6 months. The patient is healthy, off steroids, they've gained weight, they want to get rid of their stoma bag. What's the elective restorative option?
The gold standard for many patients, especially young ones, is the IPAA, the ileal pouch anal anastomosis. Most people just call it the J-pouch.
How does that actually work? What are you building?
You're essentially building a fake rectum out of the small intestine. You take the last 30 centimeters or so of the ileum, fold it on itself into a J shape, and staple it together to create a reservoir. Then you connect that pouch down to the top of the anal canal.
And that allows the patient to pass stool naturally.
Yes, through the normal route without a permanent stoma bag.
Is it perfect? Is it like having your old colon back?
No, it's a trade-off. It's definitely not the same.
Yeah.
They will still go to the toilet maybe 4 or 6 times a day, and the stool is looser. And the pouch itself can get inflamed, a condition we call pouchitis.
Why does that happen?
Because it's made of small bowel, which isn't designed to store large amounts of bacteria like the colon is, so it can get irritated. But for many young people, avoiding a permanent bag is a trade-off they're very willing to make.
And what if someone isn't a good candidate for a pouch? Say, their sphincter muscles are weak.
Then you go for what you called the nuclear option earlier, a PEM proctocolectomy. You take everything, colon and rectum sew, the bottom end shut, and they have a permanent ileostomy. It's the safest operation with the fewest long-term complications, but it's a permanent lifestyle change with the bag.
A very big decision for the patient.
A huge decision. But some patients prefer the certainty and reliability of the bag over the potential unpredictability of a pouch.
Okay, let's flip the coin. Segment 5. Managing complications surgery for Crohn's disease.
And this is where the entire philosophy shifts 180 degrees. Surgery does not cure Crohn's.
Say that again, it's the most important point.
Surgery does not cure Crohn's disease. You can cut out the disease segment, but the disease will almost certainly recur. We call it recrudescence. And annoyingly, it usually comes back right at the spot where you join the bowel back together, at the anastomosis.
So the whole strategy has to be different. It has to be bowel sparing.
Exactly. We are conservative. We only operate for complications. Strictures causing blockages, fistulas that won't heal, or abscesses that need draining. And when we do operate, we try to remove as little bowel as possible. We preserve length at all costs.
Why is preserving length so vital?
Because these patients might need multiple surgeries over their lifetime. If you keep cutting out 20 centimeters here and 30 centimeters there, eventually they can end up with short bowel syndrome where they don't have enough intestine left to absorb food and water to survive. They become dependent on intravenous nutrition.
Which brings us to the very elegant concept of strictureplasty. It's like surgical geometry.
It is. It's beautiful. Instead of cutting out a narrowed section, a stricture, we widen it, like tailoring a tight sleeve without cutting it off.
How do you explain the most common one, the Heineke-Michelitz technique?
Okay, imagine the bowel is a narrow tube. You make a cut along the length of the tube, longitudinally, right through the tightest part of the stricture. Now you have a long slit. Then you pull the middle of that cut apart so the top and bottom edges come together, and you sew it up sideways, transversely.
So you cut it long ways and sew it short ways.
Precisely. A longitudinal incision, a transverse closure. It turns a long, narrow pipe into a short, fat pipe. The obstruction is relieved, and you haven't lost a single centimeter of bowel.
Incredible. And that's for short strictures.
For short ones, yes. For longer ones, we use a Finney strictureplasty, which is a bit more complex, more like folding the bowel loop on itself and creating a big side-to-side channel.
The text also mentions a newer technique, the Kono-S anastomosis.
Yes. This was designed specifically by a Japanese surgeon to try and reduce that high recurrence rate at the join. It's a very clever bit of engineering that involves connecting the bowel on the antimesenteric side, the side away from the blood supply, and creating a sort of supporting column. Early data suggests it might physically prevent the distortion that leads to new strictures.
Fascinating. Now, joining bowel in a Crohn's patient is risky. Anastomotic leaks, where the joint falls apart, are a complete nightmare. What are the big red flags?
Baily and Love provides a very clear checklist. If a patient is on high-dose steroids,
Bad for healing.
terrible for healing. If they've received biologics very recently, if they have a low serum albumin, which is a marker of malnutrition,
What's the number for albumin?
under 30. If their albumin is below 30 GL, their body just doesn't have the protein, the building blocks to heal a wound, or if they are actively septic. These are all huge red flags.
So you see those red flags, you don't join the bowel.
You don't be a hero. You give them a stoma. You bring the bowel ends out to the skin. You let them get better, get their nutrition up, get them off the steroids, and then months later, when they are healthy, you can think about reconnecting them. A live patient with a temporary stoma is always better than a dead patient with a perfect-looking anastomosis that leaked.
I want to throw a scenario at you from the text. Case study B, the emergency appendix. You're a surgical trainee. You take a patient to theater for suspected appendicitis, but when you get inside, the appendix looks totally normal. However, the terminal ileum next to it is thick, red, and angry. It's clearly acute Crohn's. What do you do?
This is a classic caught in the headlights moment. Every surgeon fears finding this. The golden rule, the absolute unbreakable rule is do not touch the ileum.
Don't cut it out, but it's the diseased part.
Do not resect it. If you cut into acutely inflamed Crohn's disease in an unprepared patient, the tissues are like wet tissue paper. They won't hold stitches. Your suture line will break down and you will almost certainly cause a fistula. You will turn a simple tummy ache into a lifelong surgical disaster.
So you just back away. What about the appendix? Do you take it out?
That's the tricky part. If the base of the appendix where it joins the cecum is completely healthy and uninvolved, you can take the appendix out,
Why?
just to avoid confusion in the future. If that patient gets right-sided pain again, you'll know for sure it's their Crohn's, not appendicitis. But if the cecum at the base of the appendix is inflamed at all, you back away completely. Leave everything. Close the abdomen and treat the patient medically with steroids and antibiotics.
That must take a lot of discipline. The urge to fix what you see must be strong.
It is. But the right move is to recognize that sometimes the best surgery is no surgery. Primum non nocere. First, do no harm.
Let's move to segment 6. Perianal disease and cancer. This is the really nasty stuff. Perianal Crohn's.
It's devastating. It affects up to 50% of patients with Crohn's. We see large skin tags, deep non-healing fissures, and complex branching fistulas. The text uses the very vivid term watering can perineum.
Which means?
It means multiple fistula openings on the perineum, all draining pus, like the spout of a watering can. It's devastating for a patient's quality of life, their dignity, their sexual function.
And the normal surgical instinct to cut the fistula open is wrong here too, isn't it?
Completely and utterly wrong. If you perform an aggressive fistulotomy, cutting the tract open to let it heal from the bottom up in a Crohn's patient, the wound simply will not heal. You'll just be left with a bigger, non-healing wound, and you may damage the sphincter muscle, leaving the patient incontinent.
So what is the strategy?
The strategy is twofold. First, control the sepsis, drain any abscess. Second, you use aceton. Aceton is simply a loop of thread or soft silicone that you pass through the fistula tract and tie in a loose loop.
And its purpose is just to keep the tract open.
Exactly. It acts as a drain. It keeps the door open to let the pus out. If the skin heals over the top, the pus builds up behind it and forms a new abscess. The seton keeps the tract patent, preventing that pressure buildup. It buys time for the medical therapy, the biologics like infliximab, to do the real work of healing the tissue from the inside out.
So drainage first, meds second. Never aggressive cutting. Okay, let's talk about the big C, cancer.
Both diseases carry an increased risk, but it's different. In UC, the risk is very clearly linked to the duration and extent of the disease. The clock starts ticking after about 8–10 years. The risk is highest if the whole colon is involved. Pancolitis.
So those patients get screened.
They get regular screening colonoscopies where we take multiple biopsies looking for dysplasia, which is precancerous change. We look for something called a DOM.
A dysplasia-associated lesion or mass.
Right. If you see a weird, bumpy, velvety lesion in a colitis patient, it's highly suspicious for cancer. And finding one of those usually mandates a total colectomy.
And for Crohn's.
They also have an increased cancer risk, but it's a bit lower and it's harder to screen for because of all the strictures. You often can't get the scope all the way through the colon. And interestingly, they can also get cancer in the small bowel, though it's much rarer.
Okay, before we wrap this all up, let's do a rapid-fire round on the extraintestinal manifestations. The gut is the main battlefield, but the war affects the whole body.
It really does. Okay, rapid fire.
Arthritis is very common. Specifically, ankylosing spondylitis, the bamboo spine, is strongly linked.
Two big ones. Erythema nodosum, painful red bumps, usually on the shins. And pyoderma gangrenosum.
Pyoderma gangrenosum is terrifying. It starts as a small pimple and can just explode into a deep, necrotic, incredibly painful ulcer.
And again, the theme returns. You do not cut pyoderma. It exhibits a phenomenon called pathergy.
Meaning it gets worse with trauma.
It gets worse if you cut it. A surgeon who tries to debride it will just make the ulcer bigger. You have to treat the underlying bowel disease, and then the skin will heal.
Primary sclerosing cholangitis, or PSC. This is scarring and inflammation of the bile ducts. It's very strongly linked to UC.
And unfortunately, taking the colon out doesn't fix the liver, does it?
No, that's the cruel irony. Even after a curative colectomy for UC, the PSC can continue its own independent course, sometimes progressing to liver failure and needing a transplant.
All right, we have covered a massive amount of ground. Let's head to the outro and try to summarize this. If you take nothing else away from today, remember the core distinction between the twins.
Ulcerative colitis. It's mucosal, the superficial red carpet. It's continuous, starting in the rectum and moving up. The main symptom is bloody diarrhea, and it is cured by removing the colon.
And Crohn's disease. It's transmural, the tunneling moles. It has skip lesions. It can be anywhere from mouth to anus. It causes fistulas and strictures. And it is not cured by surgery. Surgery is for complications only.
Perfect summary.
Remember the true love and wits criteria for severe colitis. More than 6 bloody stools a day, plus systemic signs like a fever or a fast heart rate. That is your trigger for hospital admission.
And please remember the surgical nuances. In UC, we can build a J-pouch to restore continuity. In Crohn's, we use strictureplasty to save bowel length. And in perianal Crohn's, use a seton, don't use a knife.
Okay, here's a final provocative thought for you to chew on. Baily and Love briefly mentions the microbiome and this concept of dysbiosis, an imbalance of the bacteria in our gut. We spend hours in theater surgically removing organs, creating new pouches, and we suppress the immune system with these incredibly powerful, heavy-duty drugs. But are we just treating the smoke and completely ignoring the fire?
It's a great and very humbling question. We are cutting out the battlefield, but the war itself is likely being fought at a microscopic level that we still don't fully understand. The future of IBD treatment might not be a scalpel or an immunosuppressant at all. It might be a perfectly engineered bacterial capsule that can reset the gut flora.
A probiotic on a whole other level.
Exactly. And we might look back at colectomies for IBD the way we now look back at bloodletting. A bit crude, maybe, but the best we could do at the time.
A sobering thought for any surgeon. So, the mission for you now, listening to this. Open Chapter 75. Look at the picture of the cobblestone mucosa. Look at the diagram of the Heineke-Mikulich strictureplasty. Make these mental images concrete.
If you can visualize the pathology, the clinical decisions become obvious.
Keep your mucosa intact, stay curious, and we'll see you in the next deep dive.